Marty and the organizing committee at SAPA. It's always such a huge honor and even more of a pleasure to present to pediatricians. And I must also acknowledge Andrew Redfern and Desmina, who we're kind of we need to make some more progress, but we're putting together an algorithm for assessment of ICP in children. So I'm going to talk about some of the work that we were interested in, some that we've done, some interesting things that I thought for a pediatric audience would be appealing. So I hope I've managed to do that. And then I think most importantly, like I promised Marty, I'll try and stick to time. So the layout is I'm going to talk about the clinical assessment, which I think, a lot of you are incredibly familiar with. It's like, singing to the choir, really. The radiological features, some of which apply to you, and those we find quite important in our decision making. And then probably the bulk of the talk is on ICP monitoring techniques, some of the invasive stuff that we use, and then some of the more non-invasive techniques, which I think are growing in appeal now. If you look at, and I'll show, how these invasive techniques are done and why there's such a drive towards developing a reliable non-invasive tool. And I'm going to touch on some of the ICP management protocols and principles, but I think Ronald, is going to focus that very much on a sort of TB management protocol. So I hope we stimulate some debate there. So the background is, why would we look for a non-invasive technique like this? And I've put both specifically, the publications we were involved in, and highlight the fact that it's lovely to take out these huge, this was a hydatid cyst, and we're able to kind of publish these as case reports and claim to have some of the largest removed intact cysts. But really the goal would be to diagnose these kids early. And I think a lot of you would agree with that. And in our setting, unfortunately, so raised ICP, I would argue, is the commonest underlying presenting symptom complex for most serious neurosurgical and maybe even neurological conditions. So if we were able to diagnose this, like I've said, a few times, with the degree of accuracy that a thermometer diagnoses raised temperature, I think it would just step up our diagnostic capacity and our screening capacity for these children a lot better. So the point here is, even though it's from our point of view nice to take out an intact cyst like this, the goal would be to diagnose this so much earlier that you don't have to take out such a large tumor or a cyst or hydrocephalus, whatever the case may be. Causes of raised ICP, I put this in just for completeness, but the list is exhaustive. These are space-occupying lesions, CSF flow obstruction, really mostly hydrocephalus, edema, depending on whether it's head injury, infection, or hypoxia, or hypoxic ischemic injury, and then increase in venous pressure. And these really cover the bulk of the causes of raised ICP that we encounter. These span adults and children, so I've included some of the stroke stuff as well. Tumors, hydrocephalus, and traumatic brain injury, really that's the bulk of what we end up treating. So I've included this slide because I know the next talk will interface quite nicely with this, obstructive versus non-obstructive, communicating versus non-communicating. And I don't think any other unit on the planet has done more than the Stellenbosch group on trying to differentiate this and, work out a sensible algorithm for diagnosing it outside of just a CT scan, which is quite a blunt tool, as they've demonstrated that. So hopefully we'll have some discussion on that. We follow really in terms of how we classify hydrocephalus, Ricate's updated classification, where effectively what he argues is that all hydrocephalus is communicating, except for choroid plexus papillomas, where there's a publication claiming to show, actual seepage of CSF from the papilloma. We've operated on lots and lots of these. I've never seen it myself. I've never actually spoken to another surgeon who's seen it, but there is a description of that. So outside of papillomas or choroid plexus carcinomas, all other hydrocephalus is considered to be communicating. It's just the level of that obstructive component that varies. So CSF gets out, within the ventricular system all the way into the cistern, and the level of obstruction varies, but there is communication in most of them. The basic pathophysiology, the Monroe-Kelly hypothesis, this, I think, for me anyway, is a fundamental decider in terms of, where you can apply non-invasive techniques for assessing ICP. As far as I'm concerned, if the Fontanelle is open, that is your window to the brain, or God's own window to the brain, and there's nothing more reliable in the kid with an open fontanelle. Obviously there are other symptoms which come into play, but a bulging fontanelle is always a marker of raised ICP, and one that's flat for us is, and I think for you guys as well, quite reassuring. It's when that skull closes, that all of these these complexities come into play where we need a non-invasive reliable tool or even invasive tool for assessing ICP. Monroe Kelly, I've just added this for completeness. We know, applies to a fixed cavity. So where, like I said, the skull is closed and there isn't a fontanelle or window that allows us to assess intracranial pressure. The symptoms in kids, I think it's important, when one puts together an algorithm to start right at the beginning. So what does the parent come in complaining of with the kid? And these are the things, large head, thin, shiny scalp, irritability, poor appetite, vomiting, upward gaze, palsy, seizures, often splayed sutures, developmental delay. And it's often an interplay, between these symptoms in some sort of concert. It's never just one or the other. So that's your first departure point. In an older child, it differs. Some of them still remain the same, but I think the symptom complex becomes a little more complicated. One needs to be aware of those. The general examination, I think when talking to a group of pediatricians, you always need to include the fundamental useful stuff. So things like the road to health chart is always any mom coming into, I would say, an academic or government hospital. I find it differs a little bit depending on where you see the parents, but any mom bringing a kid into our clinic always will have the road to health chart. So you can get all of these things, the weight and height, dysmorphic features, and then you've got to do a systemic evaluation, and then measuring of the head circumference is a fundamental tool. A standalone or sort of point in time measurements, unless they're grossly enlarged, tend to mean a lot less than the sustained measurement of these over time. So it's more the trend, and I think is something as pediatricians you guys are better at than we are. But the trend over time is a better indicator of increasing intracranial pressure. And then together with that, like I said, the fontanelle and what the scalp looks like, cranial nerve palsies and the splayed sutures. Again, measuring that just makes the point that the trend over time is more important than the absolute kind of snapshot. And then numerous publications showing that this is probably your best clinical indicator of a child that's developing raised intracranial pressure, or at least a neonate with an open fontanelle. So the clinical assessment outside of that, older kids, the Glasgow Coma scale is our go-to assessment tool, combining that with ocular abnormalities, third and sixth nerve palsies, relative affluent pupillary defect, near light, pupillary light near dissociation, visual impairment, I think is incredibly important. And we've defaulted now to getting almost every child that comes in assessed by an ophthalmologist. If you have the luxury, which we're fortunate to have at Steve Baker, is, we asked them to do an OCT as well, so optical coherence tomography, and I'll show the value of that a little bit later. And if you combine all of these, fundoscopy is incredibly important, and I'll show that in the next few slides. But again, it's very user dependent. You need to know what to look for in a kid. It's incredibly difficult to do. So the fontanelle, as I've pointed out, really your go-to decider for whether a neonate has raised pressure or not. This applanation principle basically says if you assess a kid in the supine and vertical position, these things differ, so you've got to bear that in mind. But a kid with a bulging fontanelle from hydrocephalus or a space-occupying lesion, that fontanelle will bulge no matter what position the kid is in. Parinaud syndrome, again, used a lot, but I think that not many people actually know what the full spectrum of the syndrome is. So it's a paralysis of upward gaze. There's loss of accommodation. There's convergence retraction nystagmus, which you can induce with the optokinetic drum, which I've included a picture of here. Something that Jonathan Peter and his predecessor Kay de Villiers really drummed into our teaching program at Red Cross and at UCT. So we always remain thankful for that. That combined with eyelid retraction and conjugate downward gaze really form the symptom complex for Parinaud syndrome. Then what does the ophthalmological examination actually encompass? So pupillary assessment, I've just shown the spectrum of those. And then the fundoscopy, what do you look for is quite important. So papilledema is something everybody tries to see on fundoscopy. Optic atrophy, a lot more difficult to kind of pick up clearly. And then spontaneous venous pulsation. So papilledema is not just a straightforward thing, and one needs to bear in mind, it can be mild, severe, it can be resolving papilledema. There are various grades for this, the Friesen grading system. I would argue that an ophthalmologist is best positioned to do that. You need to dilate the pupil, I think. So, if you have that service, really makes a big difference. Optic atrophy, really difficult to pick up, but once a child has presents, you diagnose optic atrophy, really it's quite a sort of chronic stage with not much reversibility. The presence of spontaneous venous pulsation, you can see as this paper describes, the absence of spontaneous venous pulsation with papilledema is really the most sensitive marker of raised ICP. So when you see it, it doesn't really mean that much when there's no papilledema, but absence of spontaneous venous pulsation with papilledema really increases that diagnostic accuracy. Again, best assessed by an ophthalmologist and where available. So when you ask for your ophthalmologist, if you have that service available, it's nice to know what to ask them to do. So if you find papilledema, and I think this is quite an important point, what is the actual clinical utility? And if you look at the most cited papers here, the diagnostic accuracy ranges from 22 to 100% in some, very much age-related. The time to manifestation and resolution is a big issue. User variability, so the level of expertise of the person performing it, the degree of herniation. So when I say herniation, I mean herniation of the fundus into the globe, and the age of the patient really influenced this tremendously. And if you look at that overall relationship with ICP as a clinical marker, it's really difficult. And I'll show why that's important as this talk evolves. So if we move now from clinical assessment to radiological assessment, I think a lot of you are quite comfortable with the kind of findings on a CT or MRI scan, the assessment of the basal cisterns or ventricles, depending on whether the patient has a space-occupying lesion or hydrocephalus, midline shift, depending on whether it's unilateral or bilateral, then large ventricles, things like transepidermal fluid shift, hematoma, space-occupying lesion, blood in the subarachnoid space, and actually CSF as well, and the gray-white or sulcal differentiation. And I'll try and unpack, each one of these in terms of their relevance as we go along. So space-occupying lesions, so I think it's important to realize what a subdural hematoma looks like versus an extradural, the crescent shape versus the lenticular shape. It's quite important to pick up in that, acute setting. This is what a chronic or subacute subdural, you can see it changes in its density from hyperdense to hypo or isodense. It's quite important to, in terms of how urgently one needs to take a patient to surgery. All of these things make a big difference. Diffuse axonal injury, I've included that. This is graded, something probably we use more, and it's not that relevant outside of that, but it's quite clearly prognostic in terms of where one grades diffuse axonal injury. And the mechanism of injury, a sort of axonal shearing, acceleration, deceleration type injury is quite important in how the pathology manifests itself on the imaging. So, space-occupying lesions, tumors, something we see a tremendous amount of, depending on where the tumor is. You can see on the left, this is almost, a whole hemisphere tumor. It turned out to be an ependymoma versus a focal large space-occupying lesion with massive factor, one in the ventricle with hydrocephalus. All of these can manifest with raised ICP. Again, highlighting the point I made. If we can diagnose raised ICP in a child earlier, I think we can pick up all of these huge tumors or anything else for that matter a lot earlier, which is really the fundamental or core of what we're trying to do. So hydrocephalus, this is a typical quadri, or at least dilatation of all the ventricles. Relatively, the fourth is smaller than the supratentorial ventricles. What that means, I think, hopefully, I'm pretty sure Ronald will unpack more of that, in his talk, but this is what a shunted system looks like. So you get the shunt in the right space. You can see the ventricles have collapsed. Oftentimes it can overdrain. So you'll see that subdural collection if it overdrains. And then I'll serve you just to assess the integrity of the shunt and whether it's fractured all the way down. We often get these 3D CT reconstructions, which are pretty useful. Other imaging options, just for completeness, every child with a shunt will get a CT scan and a shunt series, just to assess the integrity of the shunt. The encephalogram I've mentioned for completeness and, just for a potential discussion point later on. Cranial ultrasound, something we've used a tremendous amount now in kids with an open fontanelle and in sort of the point of care ultrasound or POCUS. We've really tried to drive the thinking in terms of using the nerve sheath diameter, using transcranial Doppler as markers of raised ICP. All of these come with significant difficulties, but I think the more people apply their mind to it, the more they become attractive and useful. And then again, the CT scan and MRI scan. just demonstrating in a kid with an open fontanelle, how useful it is to image across the fontanelle. That's what the ventricles look like in a coronal. You can see the third ventricle. In a sag, you can see all the way down to the brainstem here, prepontine cistern. Again, I just showed what the nerve sheath diameter looks like. I'll speak a little bit more about that just now. The information we require, just for completeness sake, you want to know the ventricular and cisternal morphology. So the size of the lateral third and fourth. You want to see what the foramen of Monroe looks like, the choroid plexus, depending on whether we're planning to do an endoscopic third ventriculostomy or even a choroid plexus cauterization. You need that information. What does the aqueduct look like? Is it stenosed? Is there flow across that aqueduct? The prepontine cistern for scarring, quite an important feature for whether one decides to do a third ventriculostomy or not. In the context of tuberculous meningitis, that becomes even more complex because there's almost always scarring in that prepontine cistern. So one could argue then doing a third ventriculostomy is less likely to work, even though there is some literature to suggest that you increase or you communicate a non-communicating system if your encephalography supports that thinking. Lilliquist membrane, along those lines, we use it to plan our stoma. We want to assess the position of the basilar artery, the mammillary bodies, and we do all of them now with navigation and trajectory planning. The various types of scans, I'm not going to spend too much time. The Fiesta really is a steady state sequence that allows us to see these membranes in exquisite detail, whether they're in the ventricle or in the cisternal space. So ask for them as often as we can. The radiological criteria for outcome, we want to look at change in ventricular size. That's been described as the marker, but the more literature coming out suggests change in ventricular size, however you measure it, whether it's biventricular diameter, Evans ratio, or the frontal occipital horn ratio is less reliable. The frontal occipital horn ratio thought to be better, but if you combine that with things like the change in flow of the change in the shape of the third ventricle, whether you're measuring the flow, the lamina terminalis, or intermammillary distance, all of those things in combination are quite useful. Periventricular edema, if it's present, which it isn't in half of patients, but if that resolves after we've treated, for instance, hydrocephalus, it's reassuring in terms of the fact that we've at least treated the hydrocephalus properly. CSF dynamic studies looking for flow across the stoma is quite important pre and post third ventriculostomy, and things like distribution of CSF in the subarachnoid space, so over the cerebral hemispheres and the optic nerve sheath. So all of these are determined not just in absolute or snapshots in time, but we're looking at the degree of change. We're looking at the temporal evolution of this change, so serial scans, the age of the patient, depending on what the compliance of the skull is like, the etiology of the hydrocephalus, acute versus chronic, so bacterial or tumor hydrocephalus as related to tuberculous meningitis, I think completely different spectrum of diseases, or response to treatment, intracranial pressure, elastance, compliance, these things all affect the physiology. Again, this is just a little bit more literature showing that, how much change in ventricular size is useful. If the ventricles are smaller, but this is not associated with a clinical improvement, which one do you go for? And in those cases, up to 40% of these scans mislead you in terms of you falsely reassured, but the pressure is still up and the patients are still symptomatic. And again, a lot of patients, if you're looking at the temporal pattern, the ventricles, even though the shunt or whatever treatment we've chosen is working, the ventricles don't return to their normal size. The third ventricle I've mentioned, in interest of time, I'm just going to move on there a little bit. Periventricular edema, when it's present, again, I'll make the point that resolution of periventricular edema or lucency is something we look at quite a bit, particularly in patients that we shunt. Unfortunately, it's absent in more than half of patients with symptomatic hydrocephalus. So where it's present, it's useful, but where it's not present that often. And in neonates and younger children, the immature brain has a high water content, so it's quite unreliable in little kids. Distribution of CSF, if you're looking at CSF around the surface, this sort of transition is one that's reassuring. If you're looking at fluid in the prepontine cistern, you're looking at post third ventriculostomy, one wants to see that naked basilar. You want to see that you fenestrated all those membranes at least, in that prepontine cistern. So those sorts of things in the subarachnoid space are quite useful. CSF dynamics, pre and post third ventriculostomy, we want to see that flow void demonstrated across our stoma, whether that's over the aqueduct as a marker of aqueductal stenosis, or across the stoma that we've made in the third ventricle, post third ventriculostomy. It's quite useful and reassuring, to confirm whether there's flow across that stoma or not. The nerve sheath diameter, we've done some work on that on MRI and ultrasound. I'll show a little bit more about that. So, how do we measure this ICP? For us, still the go-to or the gold standard is invasive ICP monitoring. And there are various ways of doing it via external ventricular drain, microtransducer parenchymal monitors, extradural or epidural we tend to use a lot less now. Even the subdural and subarachnoid placement is really kind of historic. So all our transduced or invasive ICP monitoring is done really by intraventricular or intraparenchymal probes. That's what they look like for those of you interested. And then the brain oxygen monitoring is something that was driven quite hard. I think Cape Town's neurocritical care unit under Tony Figagi's guidance must be still one of the most complex and involved or productive units on the planet, actually. And using ICP and Lycox really is a game changer for kids, particularly with traumatic brain injury, and in some cases even TBM. So indications, really, if you follow the Brain Trauma Foundation guidelines, there isn't really any level 1 evidence. Level 2 suggests, any GCS below 8 with an abnormal CT scan should be monitored. And there are things like age, unilateral or bilateral posturing, and the systolic blood pressure. Outside of that, if one's looking at placing an ICP monitor where there's a traumatic intracranial mass, patients with mild to moderate TBI for neurosurgical pathology, and post-operative patients, those are ones we tend to monitor quite a bit outside of the brain trauma guidelines. The duration and contraindications, really, in the context of somebody doing that all the time, I think is important. I've included it for completeness sake, but really I think is less important in this talk. Our ICP and CPP targets, I think a lot of you would be familiar with that, but they're very much age related. And if you use a table like this to guide your treatment, I think you're very much within the kind of recommended targets. Lumbar puncture, I think, given the audience, I've just dedicated one slide to that. I would go so far as to say patients with signs of raised ICP, localizing neurological deficit should not get an LP, in any facility that has access to some sort of imaging. I would make the statement, and again, I'd like to hear thoughts on that, but imaging must be performed to exclude a space-occupying lesion before an LP. And we may be at a biased end because we end up seeing a lot of kids with brain tumors, who present with meningism for some reason and then get an LP. And, I've been involved in at least one case now where, the doctor was found liable. So I would say, if you can image these kids, please make an effort to do it. I fully understand in the context of meningitis, that differs. So I'll be open to hear some thoughts a little later. So this need for a non-invasive technique to assess ICP, I think, is fundamental. You don't want to subject kids to an invasive procedure where you can avoid it. Unnecessary CT scans come with high doses of radiation. You want a good screening tool and something that you can monitor post-intervention. So the need is pretty clear. This is a summary of the types of non-invasive techniques. I've showed clinical assessment, radiological techniques. I'll touch on just one or two of the more promising techniques outside of those. So the eye, I think, is a fundamental tool to accessing, information from the brain, particularly raised ICP. Clinical assessment I've touched on. Intraocular pressure measurement, I think, is quite important. Pupillometry, OCT, and ultrasound measurement, I think, are really where a lot of the literature and a lot of the developments have been gravitating towards. So I'll spend a little bit of time on that. So pupillometry, I think, is really promising, not on its own as a standalone technique, but if you look at the eye or the visual pathway as a continuum. So the pupil, the intraocular pressure, the translaminar pressure gradient, so the gradient between the intraocular pressure and the optic nerve sheath. I think if one's able to collect all of that data, I think it really helps or better informs our thinking. So as a standalone, there's some literature to suggest that this pupillary response is less than 10% if your ICP is more than 20. But really, when you pool that, it's not a useful standalone marker. Intraocular pressure, the handheld tonometer, what you want is something that's mobile, portable. So it's very attractive from that point of view. But again, the pooled diagnostic accuracy suggests that it's not that useful on its own. And it's difficult to interpret, like I said, because of this context of translaminar pressure gradient. So we've got two of these studies going on now in our center, trying to work out intraocular pressure and optic nerve sheath diameter, hopefully with the help of OCT and maybe even pupillometry. And if you compound that data, it may give us more useful information. It may actually confuse the whole thing more if we're not sure how to interpret it. But I think trying to collect that information in a useful way and analyzing it certainly has some appeal. OCT, I think a lot of the future developments will revolve around OCT. You can see what a patient with papilledema looks like, normal. A lot of the literature suggests that it's massively superior in terms of its diagnostic accuracy. The problem was, this big machine, you needed to move the patient to the machine. There have been advances now with this portable OCT. You can see what that looks like, and we're hoping to get one of these in the next couple of months. They're massively expensive. The reason for that is because that not everyone uses them, I suppose, if it becomes more mainstream. But the quality of imaging one gets and the ability to get that quality of imaging at the bedside, I think, is really attractive. Venous ophthalmology, I've included this just for completeness sake to show that people, put a suction cup on the eye, collapse the central retinal vein, and you then assume that that pressure that you use to place suction on the globe equilibrates to ICP. The problem is this oculocardiac reflex, and the description of hypotension and even cardiac arrest makes it quite a scary prospect, but it has been described. Outside of the eye, the ear tympanic membrane displays something called distortion product autoacoustic emissions, really useful, but I think more in the context of a research program. I'm not sure it's reached kind of mainstream use. I'll be interested to hear some thoughts. The transcranial Doppler, I think, still fundamental, but a lot of the data suggest that it's good as a qualitative estimate. So it can tell you what's low, normal, and high, but can't is very poor in terms of absolute ICP. So these are the limitations. There have been various efforts to address this. So Van Graaf was the first to describe edema of the optic disc. Heyra, then almost 100 years later, suggested that there's always an increase in the CSF of the optic nerve sheath that will always precede disc edema. And it's on that premise that we spend a lot of our time trying to measure the CSF in the optic nerve sheath. This is what the principle looks like. Now you place a probe over the eye. Those are the kind of images you get. For those of you interested, this is an incredibly useful paper by Raoul Stevens, just unpacking, how you do it, how you interpret it. And I think this is fundamental for at least reading before one tries it. We published some of this data trying to compare these values to absolute ICP, and there's a decent correlation if you use these cutoffs. And I think in kids with an open fontanelle, if you compare them, these values tend to be quite similar. So there is a relationship. The difficulty is, what is that absolute cutoff? It differs between patients. And that's something we've shown, or at least has been shown in a number of systematic reviews. So there is some difficulty in terms of, standalone and cutoff values. There have been various efforts to try and improve the accuracy. I'll mention one or two of them and some of the work we've done. This was a principle using, like a sphygmomanometer, I think I said that correctly, where you use the cuff pressure to equilibrate systolic pressure within the ophthalmic artery. There's been quite a bit of that published. You can see this by a guy called Aminaz Ragauskas. It was verified by the NASA group in Texas, and they found it to be not that useful. And, a lot of the diagnostic accuracy claimed initially, they found to be not that useful. So again, a useful technique, but I think the technology has been taken off the market now. And some of the work that we've done, we've shown, combining the nerve sheath diameter with an actual interpretation of the elasticity or stiffness of the sheath. If you combine those two, something we call the deformability index, diagnostic accuracy appears to be better. Together with that, there have been various efforts to try and simplify the diagnostic technique. So as much as you'd sort of park your car with parking control, it allows even a novice user to get good quality data. So you align these two, and if it's bad, it's red. If it's reasonable, it's yellow or orange. And if you get it, perfect or close, then it's green. There's also sort of the machine learning algorithm has been taught to measure papilledema. So if you combine that and segment out, so the more information one puts in, it allows you to do this, which really segments out the nerve the CSF and the optic nerve sheath. So eventually, if you get to this sort of graphic, it should make the whole process a lot easier. So where are things going in progress? There's dynamic imaging, morphology of the sclera, intraocular pressure. There are all sorts of mathematical modeling studies going on. So there's a lot of work, and I expect in the next 5 years, maybe less than that, there should be an advance in terms of the diagnostic accuracy. Okay, so I'm going to skip through some of that quickly. I promised Mati I'd stick to time, and I'm already a minute over. So medical and surgical management, for us, if there's a lesion, you want to remove it, CSF drainage, decompressive surgery. So you either decrease the volume within the skull or you expand the skull to create more space. In terms of medical management, the Brain Trauma Foundation guidelines are tiered and quite specific, but I think for the interest, or at least for this talk, things like the medication we'd use, hyperosmolar therapy, when would you use hypertonic saline versus mannitol, steroids, when do you use them, what sort of dose, whether you're using dexa or betamethasone really depends on availability in my experience, what type of steroid you'd use, prednisone versus beta-dexa, I think is an interesting discussion as well. The use of acetazolamide in specific indications, Lasix, TBM, for instance, is one of them, and use of anti-epileptics would be good discussion points, I think, between the two talks. I've shown some of these algorithms. I'm not going to go into sort of exhaustive detail, but basic steps is you want to make sure that the head of the bed is elevated, the neck is straight at least 35 degrees. You want nothing around the neck constricting it. You want to maintain the blood pressure, you want to avoid hypoxia, maintain normocarbia, and prevent hyperglycemia. So a lot of these guidelines are basically stuck to normal, aim for normal. So avoid, hyperthermia. They don't particularly advocate hypothermia, but suggest that, you keep at least the temperature, the oxygenation, the carbon dioxide, glucose, and blood pressure within normal. Okay, I'll skip through those. I understand the PDF will be made available for those of you who want to, but in the interest of time, I'm going to skip through that. And then just to summarize, I think both clinical and radiological assessment on their own remain quite blunt tools for assessing ICP. But if you can combine them, combining two blunt tools may make it, potentially better. Or maybe I shouldn't be such a nihilist. They do make it better. But I think even those don't give us a good enough assessment for what's raised ICP. A non-invasive tool, especially in neurosurgery, remains a holy grail. Currently, these are still limited by poor diagnostic accuracy, limited continuous monitoring. Probably the best combined is some sort of dynamic parameter together with the static ones that have been described to improve diagnostic accuracy. So I hope that helps some of the thinking in this context. I'll hear some thoughts. Marty, you can let me know. That's the end of my talk. Thanks.